Thank you, Rita, for helping us organize this great event this evening. And I want to welcome everyone to our live from Cleveland Clinic. And we're going to be talking today about acute cholecystitis, timing, tubes, and tough cases. I think this is a great educational event that highlights our entire HPB team at the Cleveland Clinic. And you represent one of 600 healthcare providers from over 70 countries that are on tonight, potentially. And we welcome you. And what I really want to do is encourage people to ask questions in the chat. One of my jobs will be to monitor the chat questions, and we'll be sure to ask the speakers. We do also want to thank our supporters, Cook Medical, J&J, and Medtronic for helping support this webinar. And let's get right to it. We're going to first have Dr. Dan Joyce, and he's going to talk to us about the timing of surgery in acute cholecystitis. Dr. Joyce.
So, time of cholecystectomy and acute cholecystitis, I think the first thing I'd say is, of course, we wish we got the stinker of a gallbladder out before acute cholecystitis happens, but that would put us out of business. Just before I get into the talking about timing, I think many of us take care of so many gallbladders on a day-to-day basis. We don't necessarily always go back and look at the guidelines and how things are described in the literature. So I think in recent times here, as we've standardized our care paths, we've relied on the Tokyo guidelines. So just for a refresher for everyone, the actual diagnostic criteria requires one local symptom, a systemic sign, and a confirmatory imaging sign. Ultrasound, of course, being the commonest tool that we use. But of course, at least in the US, most of our patients end up getting a CT scan as well. It is worth pointing out what would be considered moderate and severe cholecystitis, in particular, elevated white counts, a palpable mass, duration of complaints over 72 hours, and marked local inflammation on scans. And then severe acute cholecystitis is essentially adding organ failures to the mixture. I do think it's important to get these patients taken care of on the same admission because the burden of untreated acute cholecystitis is real. By 12 weeks, 30% of the patients will be back with gallstone-related events, including recurrent cholecystitis, pancreatitis. So I think it's a real important problem to take care of. I remember in medical school, I trained in Ireland, and I was always surprised when I came to the US that we took gallbladders out acutely, but that was merely a resource issue. What are the definitions? Historically, early was thought to be within 72 hours, and there was that golden 3 days to get to the operating room. As the data has evolved, we've started talking about within 7 days. And indeed, some of the updates to the guidelines are pushing it all the way out to 10 days. But that leads to a lot of variability in the literature. Likewise, in terms of if you do a delayed cholecystectomy, that can be anything from 7 days to 6 weeks or over 6 weeks. So it's a little bit difficult sometimes to interpret the literature. However, I think all of us can visualize these particular clinical scenarios, and we'd all prefer to be operating during that edematous phase that typically is from day 0 to day 3. And while those gallbladders can be a little bit challenging, typically that beautiful edema plane separates the gallbladder from the liver, and they can be reasonably straightforward operations. As the pathophysiology progresses, you start to get to the necrotizing phase, and most of us dislike operating on after day 7 when you see those pictures over there. There is good data from the Swedish National Registry that bile duct injury rate does increase incrementally with each day after admission. Not necessarily that that's a reason to delay intervention, but certainly I think absolutely everyone would agree that operating on these patients sooner is always, always better. But can we define whether there are situations when early becomes late and you should step back? So let's take a look and see what the guidelines show. So the World Society of Emergency Surgery recommend that early laparoscopic cholecystectomy is preferable, as long as it is completed within 10 days of the onset of symptoms. To me, that's a fairly arbitrary recommendation, and certainly we have a lot of patients that present with unclear durations of symptoms, and we get a lot of hospital transfers with patients who have been sitting around for a long time. So sometimes it's a little bit difficult to determine. And the Tokyo guidelines essentially say, take it out, no matter how much time has passed since the onset. So what's driving those recommendations? So there was a very nice randomized control trial in 2016 from Switzerland. And what I liked about the inclusion criteria from this trial is the patients had to have greater than 72 hours of symptoms. So it kind of nicely excludes those easier acute cholecystitis gallbladders, and they looked at early and delayed operations in those cases. And despite the duration of over 72 hours, early cholecystectomy had a lower morbidity, lower length of stay, shorter duration of antibiotics, and lower costs. And the operative times were similar, and post-op complications were similar. There's been several systematic reviews and meta-analyses, and they also have supported early cholecystectomy with a lower surgical site infection rate, lower length of stay, shorter duration of surgery, and probably most importantly, an improved quality of life for patients, as again, untreated acute cholecystitis leads to a lot of return to the emergency room and ongoing symptoms. And most importantly, from all of those studies, there is no difference in mortality, bile duct injury, bile leakage, overall complications, or conversion to open surgery. So we all know that these cases are difficult, but I think the take-home message is that if you delay intervention, that the outcome is not necessarily better. And that was all brought together in the Tokyo guidelines, where they broke things down into less than 72 hours, over 72 hours, and then waiting the entire 6 weeks. And length of stay was shorter, and indeed, in the current climate that we live in, the cost is significantly lower as well. I think there are a few specific populations that deserve specific mention with respect to timing, and pregnancy is one of those. Many of us will be familiar that the SAGES guidelines recommend lap chole for symptomatic biliary disease regardless of the trimester. But I think most importantly is to point out that regardless of the gestational age, with respect to cholecystitis, that pregnancy outcomes are worse when you delay surgery. So we really should be intervening on those patients in all cases for the betterment of both the mother and the baby. Again, the elderly in the past, those were patients felt to be perhaps unfit for surgery and they needed time to be optimized. Certainly you want to treat any sepsis and resuscitate these patients, but same admission cholecystectomy should remain the standard of care for patients regardless of their age. And some of my colleagues may relate to it later, but we found in looking at our data that in patients who were treated with cholecystostomy tubes and others, perhaps so-called less invasive means, had a higher mortality, and that patients do better with a definitive operation. However, despite all of that and the guidelines, I think a more comprehensive evaluation of the patient by the surgeon is also important. So I do think imaging can be helpful when you're trying to determine whether you're going to operate or kick the can down the road. So for example, these are two separate CT scans from patients. On the first image, you can see that there's some inflammation around the colon, but things don't look too bad. Maybe that patient has been stewing for several days, but that gallbladder, I would suggest, will come out without too much trouble. But perhaps on the second image, you can see there's extensive inflammation around the colon, and that might be something you may want to temporize. So, in my mind, imaging does help in the decision making too. And of course, other more dramatic things like emphysematous cholecystitis, that patient is almost always going to get an operation. But then it's important in some of these severe cases of acute cholecystitis to not forget that could this be a gallbladder cancer masquerading, and that is certainly not something that you want to stumble into unprepared for. And indeed, patients with cirrhosis and portal hypertension, you may want to run quickly away from the operating room in those cases. So in summary, I would say I'm a big fan of dealing with acute cholecystitis with definitive surgery, really regardless of the timing. But I do think imaging is particularly helpful because there certainly are instances where imaging will guide you away from an immediate operation. And thank you for your time.
So thank you, Dr. Joyce. We managed to get through with your accent. There was a question in the chat about being able to comment on acute on chronic gallbladder disease. Anything to pearls of wisdom on that?
I mean, to me, that I mean, they're always maybe sometimes a little bit more difficult when patients have had multiple acute episodes. But again, I think those are the cases where perhaps if they've had several severe episodes where imaging can be your friend, actually, particularly in those cases, if I'm worried about what things will look like, I actually do think MRI can be particularly helpful. You can almost overlay that cholangiogram over your operative field and almost anticipate what you might be looking at. Is the cystic duct short or long, and things like that. So I do think in those cases, having a little bit of a roadmap can be helpful as well. But again, if those patients come in acutely, I think those are the people that you need to get definitively treated because they're only going to be back again.
So you're a surgical oncologist. If the radiology report, you have a CT, and the radiology report does not say this could be gallbladder cancer, are there sort of things that you look for that might help you suspect it in advance?
I think, in terms of like that scan that I showed, that extreme thickening of the gallbladder wall, looking at the interface between the liver, obviously there can be perforated cases, but I think the surgeon always needs to have a high index of suspicion. And frankly, we often can bring attention to these things, and sometimes you have to ask the radiologist. Certainly, if a patient has a particularly nasty looking scan and perhaps their pain isn't as bad as you might otherwise expect, and always, call a friend, call your radiology colleagues, always run it by someone, because we certainly like to get these gallbladder cancers while they're in situ, rather than having had a oops operation. And certainly once you spill the bile in those cases, you really have upstaged those patients.
Okay, there's a question about timing of cholecystectomy and gallstone pancreatitis. I guess I'll take that one. In mild gallstone pancreatitis, sooner is better, and there are data to do it at the time of their admission for the pancreatitis that will prevent readmissions for pancreatitis and have less complications than waiting. For severe pancreatitis, we always play out the severe necrotizing pancreatitis, assuming that the majority of the damage has already been done and you're not preventing any future episodes. So play out the necrosis part. But certainly most patients, fortunately, will have mild pancreatitis, and so take it out that admission. What about portal venous air, Dr. Joyce? Should all of those get cholecystostomy tubes?
Not necessarily. I mean, if someone has portal venous air, they clearly have a gangrenous necrotizing problem. So I think those gallbladders that when you touch, they fall apart. That's exactly what happens with the cholecystostomy tube. So I would say that that's not a clear IR case for me. I mean, that may be someone that you can almost just shell out the gallbladder when you get in there.
Are there any special considerations in terms of timing for children or very elderly patients? Does age matter?
I honestly don't think it does. I mean, you always want to make sure that everyone is resuscitated. And then in terms of pregnancy, regarding the various trimesters, I mean, certainly as you get towards the end of the third trimester, um, obviously the uterus gets big and all of that, but certainly first, second trimester, the old teaching about waiting for the second trimester, I do not believe in. And again, all pregnancy outcomes are worse when you wait. So, and certainly over the first trimester is kind of perfect in a way because there's no fetal monitoring required and things like that. So, to me, it's a little bit, like when one is taught in ATLS, when you take care of the pregnant trauma patient, you're just treating the mother, and if you treat the mother fine, the baby will be fine. And I think it's the exact same for cholecystitis.
Okay, great. Thank you. Let's move on. We're going to go next to Dr. Rob Simon. He's really an expert at cholecystectomy, and he's going to help us with operative tips for the tough cholecystectomy in acute cholecystitis. Rob?
I'm Rob Simon, one of the hepatobiliary surgeons. I'm here to talk to you about tips and tricks for managing the gallbladder nightmares. And I just want to start by reviewing Stage's Safe Cholecystectomy program. We all know about this. My favorite phrase that I hear from the residents is it's just a gallbladder. And I don't think that there's anything as just a gallbladder. And so, it's important to kind of go back to the basics and always remember the Safe Cholecystectomy program, which involves a critical view of safety, understanding potential for aberrant anatomy, liberal use of cholangiogram, intraoperative momentary pause or a timeout prior to clipping any structures, and then recognizing when the dissection is approaching a quote-unquote zone of significant risk and to halt the dissection before entering that zone. So finishing the operation by a safe method other than a cholecystectomy if conditions around the gallbladder are too dangerous. And then lastly, get help from a second surgeon. So, we can all say that, yes, this is a critical view of safety. It's beautiful. It's easy. Anterior, posterior view, no problem. 2 and only 2 structures going into the gallbladder with liver in between and the proximal third of the hilar plate cleared out. But what if the gallbladder looks like this? And I think that this is where you need to have some of these tips and tricks up your sleeve. And the first tip and trick that I want to talk about is Rouvier's sulcus. So what is Rouvier's sulcus? Henry Rouvier, French anatomist, described this landmark in 1924 to kind of help with liver dissections, and it's since been found to help with the lap chole to help avoid bile duct injuries. It's a horizontal slit present in about 82% of individuals, and it contains the right posterior branches of the portal triad in about 70% of individuals. So the cystic duct and artery typically lie above that, and the common bile duct typically lies below that. So if we look here, that is Rouvier's sulcus, and the green you can see is the bile duct. And so starting your dissection above Rouvier's sulcus can help guide you away from that common bile duct. Here is a video I just want to show. It's a cirrhotic liver, pretty stiff, so I had to choke up on the liver, but you can see Rouvier's sulcus. And so I'm going to start my dissection above there. kind of clearing off the peritoneum posteriorly. You can see the infundibulum coming into view there. And again, staying high up and away. Gonna take it onto the anterior surface a little bit. And again, I'm staying above Rouvier's sulcus. Now, I like to dissect along the lateral aspect of the artery. So you can see the artery right here, and I'm staying lateral to that, to the patient's right. And that opens up the hepatocystic triangle, kind of drops the artery away, so they can really get that critical view of safety. Two and only two structures going into the gallbladder, liver in between. This is me trying to perform a cholangiogram. You can see there's actually a stone in the way, so you kind of have to milk that back if you're using the Kumar clamp. I'll talk about that more later. So moving on, subtotal cholecystectomies, hot topic of conversation in terms of preventing bowel duct injuries. But the official SAGE's recommendation when talking about a laparoscopic cholecystectomy is that a subtotal cholecystectomy is preferred over a laparoscopic top-down approach. The reason I bring this up is because oftentimes surgeons, talk about a bailout operation of, oh, I can't, the critical view of safety, the hepatocystic triangle, it's all inflamed, so I'm going to come from the top down. And again, SAGE's does not recommend that. Subtotal is suggested in the setting of marked inflammation and chronic biliary inflammation. There's been some studies that have actually shown that a laparoscopic top-down approach has higher rates of bowel duct injuries. And part of that is because you lose the retraction and you lose the view that you're supposed to get to kind of help identify those critical structures. So when we're talking about a subtotal cholecystectomy, there's two types, a fenestrating and a reconstituting. And which one's better? Well, the ideal procedure when a critical view of safety is unable to be achieved does not leave a remnant gallbladder that will become symptomatic and require a later operation, has low morbidity from bile fistulas, can be done laparoscopically, and can be done by a general surgeon without additional fellowship training in hepatobiliary MIS. So, fenestrating, you leave the back wall of the gallbladder on the liver, you open it up, you remove all of the stones. You remove all of the stones, and you are left with the cystic duct orifice. And they describe that if you see the cystic duct orifice, you can try closing it with a purse string suture. But, in these cases, I would leave a drain. You don't have to close that. Oftentimes, the cystic duct is so inflamed, it's chronically occluded, or there's a lot of inflammation and you can't necessarily make out the cystic duct orifice. And again, you don't want to be blindly suturing. So don't feel like you have to do that. You can just leave a drain, make sure it's well controlled. Fenestrating subtotal cholecystectomies do have a higher rate of bio leaks from that cystic duct stump, obviously. As long as it's well controlled, oftentimes they will seal up themselves if the output's low, or if you put do an ERCP and a stent, they will seal off in over 90% of those cases. A reconstituting subtotal cholecystectomy is where you, again, stop before the hepatocystic triangle and you oversew or you staple across the infundibulum. The key for this is that you have to remove all the stones. If you leave the stones, they're just going to keep having problems. So you got to remove all the stones before stapling across or closing off the remnant gallbladder. So here's a study looking at the outcomes from subtotal cholecystectomies, and this found that fenestrating had more bile leaks compared to reconstituting, 18% versus 7%, but they had a lower symptom recurrence rate, about half the recurrence rate of the reconstituting cholecystectomy. They both had similar reintervention rates, about 30%. This is another study. The takeaway from this study is that long-term morbidity was higher in the reconstituting group, and that was solely due to issues with the remnant, suggesting that the fenestrated technique is potentially better. And then lastly, here's another study looking at early and long-term outcomes. This study shows that out of 168 subtotal cholecystectomies, there were no common bile duct injuries or need for reoperations. 7 had retained stones, and of those, they were all in the reconstituted gallbladders. So again, one could argue that the fenestrating subtotal is the way to go. So now I want to move on to intraoperative cholangiography. Has a sensitivity of about 59 to 100% in diagnosing choledocholitis. Part of that is, operator and interpreter dependent. And there's potentially a decreased risk of bile duct injury, particularly in acute cholecystitis patients. The point that I like to drive home to the trainees and to some of my colleagues is that in those acute cholecystitis patients, or in those times where you really want to do a cholangiogram because you are concerned for choledocholitis or you want to identify anatomy, those are typically the hardest times to do an intraoperative cholangiogram. And so, doing them in the easier cases, to be familiar with them and see what normal looks like in terms of the interpretation of the cholangiogram, as well as learning different techniques so that you have a plan A and a plan B for when you do get to those more difficult cases, can be beneficial and really save you. And the SAGE's recommendation officially is that that one should have a liberal use of intraoperative cholangiogram. A study from 2001 out of Sweden looked at about 613 bile duct injuries out of over 150,000 cholecystectomies, and there was a 34% risk reduction with intraoperative cholangiogram was used. A newer study out of Sweden found that the use of intraoperative cholangiogram, or even the intention to use an intraoperative cholangiogram, was associated with a reduced risk of bile duct injuries in patients with acute cholecystitis. And so, again, these are all retrospective, studies. There's a lot of weaknesses to the studies, but there is some suggestion that an intraoperative cholangiogram can be helpful, and I strongly encourage you to do it. And so this is an example of a normal cholangiogram. You can see common bile duct, the duodenum filling, no filling defects in the distal common bile duct, and the intrahepatic bile ducts are filling as well. This, however, is an example of a cholangiogram on a patient that came in with an iatrogenic bile duct injury. And at first glance, you can see that the intrahepatic bile ducts fill and the duodenum fills. But if you look closer, you can see that there is a low insertion of the right posterior bile duct that was previously clipped. So they had started to clip structures before defining anatomy, and they inadvertently clipped a right posterior branch of the hepatic artery, or hepatic duct, sorry. This is another example of an iatrogenic bile duct injury that got transferred to me where they did not shoot a cholangiogram at the time of the initial operation. And you can tell that they clearly didn't know where they were because of all of the clips. If you see more than, and if you find yourself placing more than 6 clips, that should kind of warn you that maybe you need to identify anatomy and maybe you're in the wrong spot. This is another example of an intraoperative cholangiogram that was performed after the fact, and that they had performed a bile duct injury as well. So, what about percutaneous cholecystostomy tubes? This is just a video that I like to show, a difficult gallbladder. You can see the perc chole tube kind of peeking out through there, and I find it helpful to leave it in place initially because it can help you identify where that gallbladder is. So you can kind of follow that down to the gallbladder itself, carefully dissecting. And then once you find the gallbladder, I take the cholecystostomy tube out, because that see if it's still in, it really prevents the retraction of the gallbladder up over the dome of the liver. And so I take it out so that I can then retract better. I like to take a lot of these adhesions laterally as well, so that it doesn't tear and cause the liver to bleed. And then the rest is your cholecystectomy. What if you have a big floppy liver? We've all been there. It's getting more and more prevalent, although hopefully with medications this will go away. But in these big floppy livers, it's important to have some tips and tricks up your sleeve. So if you have an assistant, you can have them hold, put an extra 5 mm port in and have them hold that liver away, but it keeps falling in your view. And so you can use liver retractors. So, here's an assistant kind of pulling that liver away. But if you don't have an extra set of hands, using any one of your liver retractors can be extremely helpful. It's not worth the fight. Put that extra 5 in. 5s are free. Dropped stones. So we've all gotten into the gallbladder. We've all spilled stones. Complications of a lost stone, about 7%. They're typically late complications, and so you got to be meticulous. So this is a case where these stones are being dropped, and I'm just kind of collecting those as they fall out, keeping track of them. I know they just keep coming, but we get them out, we put them in the bag, we use the Pac-Man to take them out. And then the key is irrigation afterwards. So the stones tend to get caught in between the liver and the kidney. So I hold the liver up, hold the fat down, and then irrigate. Stones tend to float. So if there are any stones that got lost down there, they will float up, and then you can grab them at that time. This is just an example of some dropped stones, a late complication. There's a couple little abscesses by the liver, between the liver and the kidney. So in summary, just want to talk about some key takeaways. So stay above Rouvier's sulcus. Subtotal cholecystectomies are okay and favored fenestrating subtype. Do lots of cholangiograms. Use percutaneous cholecystostomy tubes to help you identify the gallbladder. 5s are free, and then be meticulous about dropped stones. Thank you very much.
Okay, Dr. Simon, a couple quick questions for you. What about if you have an impacted cystic duct stone? You're going to have to talk fast now.
An impacted cystic duct stone.
Yeah.
So I would try and dissect a little bit more distally, carefully, over to try and get distal to that stone, so you can take the cystic duct where it's clear. The other option is you can make a cystic ductotomy proximal to the stone and kind of milk that back to try and get that.
The other way to do it is just to. So it's one of the reasons that intraoperative cholangiography is a good idea, because an unsuspected stone you will find as you sort of need to pop it out to do the cholangiogram and get bile back. But I often will actually cut, if I see the stone in the cystic duct, I'll cut right on it and pop it out right there. So that's a really good question. There's a question about ICG. Good, bad? Should we do it? Does it show a difference?
It's great. ICG helps you identify anatomy. It's not perfect, but it's a great adjunct. It's cheap. It's quick. If you have the capabilities at your hospital.
There's no downside, is there, as long as you have the equipment?
Yeah, as long as you have the equipment, go for it.
You just have to remember to give the ICG in advance. We do it at the time in the operating room, as soon as possible in the operating room. We also dilute it significantly. There's a question about what is a posterior hepatic duct. You mentioned a posterior hepatic duct. What is that?
So there is the left lobe of the liver, and then there's the right lobe of the liver. The right lobe of the liver has an anterior and a posterior section. And so there is a bile duct that goes to each of those. So there's a right anterior bile duct and a right posterior bile duct. And sometimes
Yes,
that
and that can
right
be extrahepatic.
Yeah.
Okay. Any tricks for Marizzi's?
Get an MRI. I think a pre-op ERCP with a stent placement is extremely helpful in those cases. And then, the other thing too is refer to a hepatobiliary surgeon, because oftentimes those end up eroding into the common bile duct if you're, if you're really concerned about it and require an H-check.
Okay, great. Let's move on. Thank you. Sam Nafuji is going to carry on your discussion actually and talk about what if you do a subtotal cholecystectomy? Are there any long-term consequences of that decision? Sam is a surgical oncologist also, and he's at Fairview, part of our HBB team. Sam, the floor is yours.
Hi, everyone. Thanks for being here. I'm Sam Nafuji, as Dr. Walsh said. I'm part of the surgical oncology and HPB team. It's always hard to present after Rob because he always has these cool images and videos, but I'm going to try to carry on the conversation that he started about subtotal cholecystectomy. As he mentioned, we use it in difficult gallbladders and severe inflammation, unsafe view. The view of safety is not achieved. And it's summarized in the inability to have a circumferential control around the cystic duct. We were not able to dissect it, skeletonize it, and clip it. The point is to stay away from the confluence with the common hepatic duct to prevent a bile duct or a hepatic duct injury. And there are two types, the fenestrating and the reconstituting. And the fenestrating is where the gallbladder is transected above the infundibulum. The stones are evacuated. And then if the cystic duct orifice is seen, you can purse string around it. Usually the fenestrating used to be the kind of the conventional subtotal cholecystectomy type, but recently we're seeing more and more of the reconstituting because of the increased usage of the mechanical staplers. The control becomes a little bit higher circumferential above the infundibulum, and a lot of people, for safety reasons, they don't dissect any lower, closer to the bile duct, and the stapler is used to cut and close the cystic duct. The cystic stump. Today I'm going to be focusing on the long-term outcomes, which they usually come from this type, the reconstituting cholecystectomy. We recently did a systematic review and a meta-analysis in a series, state of the art. It's going to come out soon in the Journal of Gastrointestinal Surgery. The fenestrating subtotal cholecystectomy is almost always associated with higher rates of short-term complications, and you can imagine it's because of the open cystic duct orifice. So we see more bile leaks. We require more ERCPs to do the sphincterotomy and kind of prevent this back pressure that can keep the leak from the cystic duct. So preferentially goes through the sphincter, and now that becomes obsolete or dysfunctional and it seals. And the overall complication rate anywhere from 25 to 50%, whereas the reconstituting is the one that has lower short-term outcomes but much higher long-term outcomes, and that's mostly because of the retained stones. It either retained stones in the cystic stump that was left behind or in the common bile duct, causing more symptoms of similar to the biliary colic. Mostly the patient had those symptoms even before surgery. So I chose to steer this conversation in more of a case scenario type presentation. So I actually had a case series of probably 9 or 10 in the past year. I chose a few of them to present really quickly. The first patient is 69, female, had a lab converted to open cholecystectomy without a cholangiogram. It was described as a purulent acute cholecystitis about a couple of years ago. She came to me in October a few months ago with ongoing episodes of right upper quadrant pain, very similar to her preoperative episodes. I'm going to show a video here, and this is the MRI that she had. And you can see here a very long cystic stump, thick and inflamed, with a little bit of a remnant here and a stone. And the bile duct itself was pretty clear. Not a great MRI, was done somewhere, but that's how it came to me. And this is her ERCP that was done also before surgery. You can see a very long stump. I initially was concerned that this is a leak. Actually, this is her duodenum, but a very long cystic stump. And based on the finding on the MRI, I suspected that ongoing cholecystitis is the source of her symptoms. Took her for an open cholecystectomy, took the cystic duct down to the confluence, shot a cholangiogram, and everything is clear. Patient recovered relatively quickly, and she's symptoms-free now. A second case is pretty similar, a tough laparoscopic cholecystectomy without a cholangiogram, dubbed as Tokyo 2. The patient recovered well, but very shortly after started having similar symptoms. Another example of how these stumps look like after surgery. You can see here, this is the remnant stump. I'm gonna go back here. A stump with a couple of decent sized stones inside, and in the bile duct, the arrow sign indicating a concern for a choledocholitis that turned out not to be choledocholitis, just some artifact. But again, right upper quadrant incision, took the cystic duct down to the bile duct, good cholangiogram. The patient here actually had an ERCP with a stent prior to surgery, so this is a little bit of a shadow of the stent, but also recovered quickly and symptoms went away after the second operation. The next level of problems is when we have choledocholitis. The stones are seated deep in the bile duct, causing this back pressure, constant symptoms, and sometimes jaundice. This is a 42 female who had a gastric bypass and a synchronous cholecystectomy over 15 years ago, a little bit extreme. Over the years, she was having on and off symptoms, but then escalated in frequency and severity in the past year. Very highly suspicious for a biliary origin. So we did an MRI, and this is what she had. Dilated bile duct. And I'm sorry, I'm going to pause here to show you. This is the big cystic stump with a lot of sludge. And down the bile duct, there is a filling defect at the bottom, suggestive of an obstructive body, most likely a stone. So this is a video of her intraoperative cholangiogram. Took it down, and then you feel the resistance, and then under a little bit of pressure on just the cholangiogram, you'll see it, the stone pops, and then this becomes free. I was preparing to do a bile duct exploration. I usually, this is a gastric bypass patient. We do have options to do them endoscopically with GI, but they require an edge, which is connecting the gastric pouch to the remnant. But here, intraoperatively, it's always better to do it in the same procedure. I'd sometimes go transcystic using a choledocoscope, sometimes transductal to open the big bile duct, and I can still pass the scope down and retrieve the stones. So this is how the remnant clinically looked, and actually there was a lesion that I learned about from that case. It's called the ICTN. Turns out to be a high-grade malignancy precursor. So that ongoing inflammation actually was driving the patient in the trajectory of a gallbladder cancer. So was done timely. We got lucky on that one. The last case, which is probably my extreme, was a 60-year-old also Roux-en-Y gastric bypass 20 years ago, multiple surgeries. Subtotal it was described as a cholecystectomy in 2018, but that actually turned out to be a subtotal, a reconstituting subtotal. The intraoperative cholangiogram was done at the time, and it did show no filling of the duodenum with possible choledocholitis, but for some reason, an exploration of the bile duct, or at least an attempted ERCP, was not done. The patient lived with the symptoms for many years, eventually started developing subhepatic abscesses, required multiple hospitalizations, including 2 ICU stays with drains and IV antibiotics. And she always had bile in the drain with some pus, and always normal bilirubin for some reason. That this is why probably her workup was always truncated short. She never got the full evaluation. But this is when she presented to the hospital with one of the abscesses. You can see this wedge shape collection under the liver that tracks all the way to where the cystic duct clips, or whatever those clips were placed on here on the gallbladder. And there are more clips that were placed more proximally. Eventually, this turned out to be actually a staple line on the gallbladder. And then as we went down, I actually suspected on the CT scan that there might have been a gallstone in the bile duct. So I asked for an MRI. And indeed, there was. I'm going to track it down. It was read as negative, but there is a stone that you can see at the very bottom of the bile duct. So I took the patient to surgery. This is her intraoperative cholangiogram. Sorry, I'm just going to play the video. Same thing. I was preparing for a bile duct exploration, but thankfully under a little bit of pressure, that stone was pushed down and the cholangiogram became normal, did not require a bile duct exploration. It was just an open redo cholecystectomy. The practical takeaways is that the reconstituting, even though it's becoming used more frequently recently, is associated with lower rates of bile duct leak. It's safe technically, but it does come at a higher cost on the long term, mostly related to the retained stones. I always say, always attempt an intraoperative cholangiogram, get information. If you're using the stapler and you want to staple the stump higher than the infundibulum, I would say at least use the Kumar, stick a needle in the stump and shoot a cholangiogram, see the anatomy of the remnant gallbladder and the bile duct. The better option is, like Rob said, always attempt to clear the stones if you can, open the gallbladder, get the stones out, and then reconstitute, suture or restaple if you have to. And this operation can be done laparoscopic or open, depending on the expertise. The redo cholecystectomy, I mean. And it all depends also on the surgeon's readiness to do a bile duct exploration in case of choledocholytitis. If ERCP expertise are available, that also is another great option. Thank you.
Okay, thanks, Sam. Here is a question from the chat. You put in the laparoscope. There's a phlegmon involving the gallbladder and the colon. You don't see the gallbladder. Any suggestions other than opening? And if you opened, you found the same thing. What would you do?
So one of the bailouts is to at least try to identify the fundus of the gallbladder, see if you can at least clear out the stone and put a Percoli tube surgically, or at least an external drain surgically, turn it into a controlled fistula over time. We can always come back later, but that would be one of my bailouts, is to convert to open and see if I can at least get the stones out and drain.
What about not converting and just backing out and doing a cholecystostomy to percutaneously and come back another day?
That's another option.
option. Okay. Okay.
I think just to add to that, that's where, you know, the imaging can be particularly helpful. If you really have someone that really appears to have a severe episode, often imaging can help you predict those things. Obviously, sometimes you do end up in the operating room, but a CT scan is golden, I think, in those cases.
I agree.
Yeah, and sometimes what seems terrible gets a little bit better with patience and a nice sucker and just sort of try and tease it off. Patience is a virtue. Okay, I am going to be Katie Stackhouse. Can I get her slides? Katie is one of our HPB surgeons in Akron, and she is still operating. So I'm going to help her out. And the question here is, who needs a percutaneous cholecystostomy to? So, okay, thank you. You're going to advance my slides, right? So I think we've already heard that the standard of care for acute cholecystitis, and you may need tricks and tips from Rob Simon, but the treatment is cholecystectomy, not cholecystostomy. Percoli is an option for high-risk patients due to medical comorbidities or prohibitive surgical risk. Next slide. So what does that mean? That's always been a little bit of a challenge. What is someone's high risk might be different from surgeon to surgeon, maybe even time of day may matter. So really high risk is comorbidities that could be optimized to make the operation safer at a later time, such as anticoagulation that can at some future point be reversed, or they have prohibitive surgical risk, and that can be defined by the American College of Surgeons NSQIP totally available mortality risk calculator. People who have cirrhosis, we saw an example of that earlier with a lot of varices around the gallbladder, or who has an ASA class 4 in terms of anesthesia risk. And the other category are people who are not expected to live more than 6 months. So those are high-risk patients. There's actually a trial, a very good trial in most respects. It's called the Chocolate trial that actually did a randomized study looking at whether to do cholecystectomy or per chole in people who were of acceptable surgical risk, but had severe acute cholecystitis. We have the next slide. And this study randomized people, and just as Dr. Joy said, we want to do cholecystectomy earlier. So people who were randomized to cholecystectomy were done within 24 hours. And you can see in the top box, they did Apache 2 scoring, which is really an objective way to assess patients. And you see they're greater than 7, but less than 14. So that means that they're not actually the sickest patients, okay? Greater than 14 would be the absolute sickest patients. So it's not those patients. These are people that were still deemed to be surgically acceptable, but had bad acute cholecystitis by the Tokyo guidelines. And so if they were randomized to cholecystostomy, let's see what happens. You'll notice that if you follow down the cholecystostomy pathway on the right, that they did eventually take out the tubes. And this excluded patients with acalculous disease, okay? So that is interesting because I think it's a different discussion in acalculous. Next slide. So what happened? So cholecystectomy was better. You'll see the major complication rate is significantly way much better. The need for reintervention, way better. Recurrent disease, much, much more favorable. So really, in people who have acceptable surgical risk, cholecystectomy is the treatment. Next slide. Now, we did think it was interesting. Okay, we looked at this. This is our study looking at cholecystectomy in people, and it was pretty high. And the re-interventions were also high, but you see that a lot of people died. So I would say it just means it still is acceptable in people who have really poor long-term survival chances to do a cholecystostomy instead of cholecystectomy. But the deaths were due to their underlying disease. Now we get some sick patients here, but so keep that in mind. Next slide. What we did, we tried to standardize a treatment approach to people with acute cholecystitis and when they shouldn't have cholecystostomy tubes. Now it is interesting, when the Tokyo guidelines were updated, at that same time, worldwide, there was an uptick in cholecystostomy tubes. So it was our feeling that probably we were overutilizing them. Next slide. So we tried to define really, is there a next slide, please? I hope there is. Yeah, this is a blow up here. And you can see, if you look at the box on the left, we really tried to define what was severe. So you'll see it's a NSQIP calculator from the American College where mortality is predicted greater than 10%, or they have cirrhosis or SA class 4. Those are really the clear guidelines. And unless they had that, they got cholecystectomy. So if we go down the pathway, keep going, you'll see that most people should get a cholecystectomy. Otherwise, they can get a cholecystostomy or endoscopic interventions. Next slide. And we published on, well, what happens? We did this as a system. So all of our hospitals in Northeast Ohio, they had different rates of cholecystostomy, but you can see on the left, upper left, that our cholecystostomy rates and our mortality rates went down and our cholecystectomy rates went up. So we did this as a standardized approach, and I think it was very effective. Next slide. I think this is a conclusion slide. So percutaneous cholecystostomy should be used in, it's still an acceptable procedure in people who have high prohibitive risk, or you can reverse some of their medical comorbidities. But otherwise, it is inferior to cholecystectomy. Okay. Any questions? Okay, so there is a question about EUS guided cholecystostomy via the duodenum. And yes, we do that on occasion, where we don't want a cholecystostomy tube, especially, patients are never in favor of that. So we do select patients who we think are good risk in terms of that procedure and are a poor risk for surgery. Yes, someone is saying before 1990. Okay. So for us younger surgeons, are we just not as good? Well, that's a given.
You're not allowed to answer this, Dr. Walsh.
Yeah. Okay, let's go to some cases. Maybe we'll get more based on cases. There's nothing wrong with cholecystostomy in the right patient setting. It's a perfectly fine thing. But the other thing I should mention, I guess, is that I think surgeons should be making that decision, not intensivists who have an ultrasound, who have skills, who can do percutaneous procedures. Let the surgeons make that decision. So get involved in your hospitals. Make sure you're accessible and able to do cases. See patients. Okay, so Brianna is our HPB fellow. She has a bright career ahead of her in HPB surgery. So she's going to talk to us about a patient she's taking care of. So Brianna, the floor is yours.
All right, thank you so much. So this is an interesting case that I saw in conjunction with one of our other HPB staff members. And this is in some ways going to continue the conversation brought up by Dr. Nafuj as well. So really, this is an interesting patient who presented with choledocholithiasis and initially this concern for liver metastases. So this patient had both bypass anatomy and some unusual imaging findings. So we'll go through this case. All right, next slide. So briefly, this is a 61-year-old female who had a remote history of a Roux-en-Y gastric bypass, and she initially presented to the emergency department due to both chest pain and abdominal pain. And on her initial workup, she was found to have elevated liver function tests, as you can see there. Not through the roof, but definitely elevated. And this triggered an MRI for further evaluation. So let's go to the next slide and we'll take a look at that. All right, so this is a coronal. As some of the other staff have already shown, I think coronals are very helpful for looking for choledocholithiasis. So you'll see here several different things, an enlarged gallbladder with cholelithiasis, and then also choledocholithiasis. And then of interest, she has these innumerable T2 hyperintense lesions in the liver that at first glance, you may not think too much of as, innumerable cysts that may not be of too much concern. But keep going to the next slide. Next one. Yep. All right. So I think this is really important. And one of the things that I've had the benefit of learning during my training is really becoming an expert and trusting your own read of MRI imaging and not being just limited to kind of the most traditionally high yield sequences, such as the HASTE images, the heavy T2 signal images, but really looking at the diffusion weighted imaging and the corresponding ADC. So on the left, I'll just have you rerun that one more time. You'll see there are mixed within the innumerable cysts, there are actually several, mostly sub-centimeter, but the largest one is about 1.8 centimeters in segment 8. There's also one in segment 4. There are several bright spots that you'll see on the diffusion weighted imaging on the left. And then when you look at the corresponding ADC sequence on the right, they're dark. And so that combination of bright on diffusion weighted imaging and dark on ADC should really pique your concern for a true diffusion restricting lesion. And so thankfully our radiologists here were quick to point that out and brought it to our attention. Next slide. All right, so this was ultimately the official kind of first pass read on this MRI for this patient. They noted the cholelithiasis, choledocholithiasis, the innumerable bilobar hepatic cysts, and then, as we talked about, the numerous bilobar T2 hyperintense, diffusion restricting, and hypo-enhancing lesions that they read as suspicious for metastatic disease. So obviously you see that read come across your desk and you have to, really take a close look. And then also, as surgeons, we have the full clinical picture of what's going on with the patient, whereas our radiologists don't always have all of that information. And I think that's why it's so important to talk to them and have a really great line of communication with your radiologists. Next. So what are the options here? What needs to be addressed in this patient? So as it relates to this talk, of course, we have to address the gallbladder disease, the cholelithiasis, the choledocholithiasis, and then what do we need to do about these liver lesions? So we have a couple options, and these were several of the options that we discussed. So you can plan for a laparoscopic cholecystectomy and a transcystic common bile duct exploration to address the choledocholithiasis. You could also do a cholecystectomy with a common bile duct exploration and a choledochoduodenostomy if this were a patient where the stones are really large and you're concerned about recurrent stones. Of interest, I think oftentimes we think of Roux-en-Y anatomy as really just all downside, but remember in her, if you're going to do a biliary bypass with a choledochoduodenostomy, you wouldn't have to worry about sump syndrome in this patient. And then also you could do a laparoscopic cholecystectomy and then involve your advanced GI colleagues. So as was mentioned by Dr. Nafouj, this could mean a lap-assisted ERCP, or it could mean asking your GI colleagues to perform an edge procedure, as he mentioned, getting access to the remnant stomach, and then do your ERCP and ultimately a cholecystectomy. So the considerations really have to include your available resources, your expertise, both for your surgical team and your GI team, and also the patient's clinical condition, their fitness for surgery. How much time do you have to address this issue? Are they acutely cholangitic? Do you need to intervene as quickly as possible? Or do you have some time to arrange your different resources? So a lot of different factors can play into it, but I think it's very helpful to think about all your potential options so you know that you're really picking the best one for the patient. All right, next slide. So we talked about this patient and her imaging with our radiology colleagues again. And when we brought up the full clinical picture of her choledocholithiasis and on further discussion with the patient, what sounded like some actual kind of chronic brewing symptoms for quite some time, we actually realized that those diffusion restricting lesions were actually probably abscesses that were happening as a result of chronic intermittent cholangitis rather than malignancy, as she didn't have any other indication of a malignant process happening. So we elected to take the patient to the operating room for a planned laparoscopic cholecystectomy and then a plan for a transcystic common bile duct exploration using choledocoscopy and then also taking a biopsy of the liver to ensure that we weren't missing anything else more nefarious going on. Next slide. So we were performing our cholecystectomy. As you've heard from everyone else, we perform cholangiography very consistently and liberally. So this was our initial cholangiogram. You can see the common bile duct is dilated. We have filling of our common hepatic and our hepatic branches. But you see there isn't really good filling into the duodenum, and that obviously, given her preoperative imaging, made us concerned for the choledocholithiasis still being an issue. Next slide. So this is a video of the choledocoscopy, the transcystic common bile duct exploration that we did. Go ahead and play that. And what you'll see here is a view of the common bile duct and see a big stone sitting right there. What I think a lot of people may be surprised by if you're not as familiar with having choledocoscopy available to you is that the imaging quality is now excellent. You can see everything really nicely. You'll see that we've advanced a basket past that stone. You see the basket deploying there, grabbing the stone, and then it is retrieved through the cystic duct, just like that. And next slide. And then, of course, after you have addressed all of the stones burden that you believe that need addressing, you always want to perform a completion cholangiogram to confirm as well. So we did a completion cholangiogram, and you can see there very nice rapid filling of the duodenum and no distal filling defects. And of interest, the pathology report was chronic cholecystitis and a bile duct hamartoma with no evidence of malignancy in the liver. Next slide. So I think there are a couple useful takeaways from this case. First is really careful interpretation of your imaging findings and using your expertise as the clinician seeing the patient and taking a really detailed history to really put the imaging findings in clinical context, which our radiology colleagues don't always have. And so that really can change the course of your clinical management of the patient. And also thinking again about what are all your different options for managing choledocholitis, especially in patients with unusual anatomy, bypass anatomy, as we talked about those options previously. And then the other thing to keep in mind is, I know we talk a lot about lap-assisted ERCP or an EDGE, but you have to remember, not all patients with a Roux-en-Y anatomy necessarily have a remnant stomach. So if there's no remnant stomach, then EDGE is not an option. A lap-assisted ERCP is not an option. So I saw that come up in a patient just last week. So you really have to study their preoperative imaging and their surgical history carefully. So also, it's not always that you have access to choledocoscopy, but I think it's really helpful to know that it's actually the learning curve, I think, is very reasonable and quick. You have great imaging quality in the OR, and if you do have that available to you and you're able to do it transcystic, you can really address all of the issues, save the patient an additional endoscopic procedure, and be able to address all the issues at the same time. So I think this patient was, the perfect example to be able to kind of address everything with minimally invasive tools. So I hope everyone enjoyed that case and could see some of that great choledocoscopy video.
Okay, thanks, Brianna. I don't see any questions. I do want to make sure Maureen, who is the best participant on the chat, keeps coming to every one of these webinars. She's very enthusiastic. So let me.
I did see there was one question about someone asked about a patient with a persistently occluded cystic duct after a percoli. I would say take the gallbladder.
Answer. You didn't like my answer?
Oh.
Yeah, can I make a small comment on that one?
Sure, go ahead.
We had a couple of patients with persistent percutaneous cholecystostomy tube and irreversible prohibitive comorbidities. We could not optimize them to go to surgery. On the MRI, it was a impacted stone in the cystic duct, a few of them, not too many. So actually, we've done a couple of patients here where we upsize the tube to a 16 French, and we can use the choledocoscope just to clear the stones and eventually take out the tube if the cystic duct opacifies, if it's still patent. We do them under sedation. Obviously, the patients did not go under general anesthesia for a reason, but that's a kind of an extremely rare situation. We only have two or three patients, I think.
Okay.
But I think the cholecystectomy is the right answer if the cystic duct does not opacify over time.
Yeah. Brianna, what if the cystic duct isn't big enough for your choledocoscope?
Yeah. So sometimes, so just to reiterate Dr. Joyce's point from earlier, I think this is where the preoperative MRI is very helpful because you can get a sense of that preoperatively and have a sense of, whether you're going to be able to do it or not. Some folks will try to pass a wire through the cystic duct and feed that down into the common bile duct and then be able to try and basket under fluoro. That would be an option. But if you're still not comfortable with that, then I think, as Dr. Simon mentioned, you have to think about your readiness to perform a common bile duct exploration and pursue that option. And if not, then I think refer to a center that is able to offer that patient or ability.
And you can balloon it too.
Balloon the cystic duct too.
Yeah,
that's true.
To dilate it a bit.
Yeah.
Okay, but I do think you are correct. You can predict ahead, or at least plan. Like in your case, you could open the bile duct. It was nice and big and juicy. Mm-hmm. Okay, Rob Naples, I think we have time for you. You're going to be fast though, right? We have a lot of participants still on, so everyone's excited. I understand why. But Rob Naples is an HPV surgeon on the team at main campus, and he has another case. Let's have the next slide. Let's go through it together.
Yeah, let's see what it's about. So 68-year-old male, complex cardiac history, CKD stage 3, and BMI of 40. Presented to the clinic with acute calculus cholecystitis, status post a percutaneous cholecystostomy tube. Perfect. About a week prior to his cholecystitis episode, he had a right AKA due to a prosthetic joint infection, and found to have a DVT during hospitalization and placed on Eliquis for 3 months. So a lot going on here. Let's go to the next slide.
Hey Rob, I'm back on.
Oh, there you go.
Okay.
Take it away, man.
Yeah. So this was his, I saw him about a month after his admission, but this was his CT scan on admission when he got the Percoli tube. So we had a good amount of inflammation there. The colon is pretty close by. You could go to the next slide. So I saw him, about a month after he had this Percoli tube in. He was supposed to do 3 months of Eliquis for that new DVT. So I thought, why not just finish that Eliquis? So I was planning to do it 3 months after the Eliquis, so I didn't have to restart that. At some point during this 2-month time period, his Percoli tube got dislodged. He had about 1 more month of Eliquis. He had no symptoms. And I just routinely get a CT scan in these patients with Percoli tubes prior to the cholecystectomy just to take a look at the inflammation. So we could go to the next slide and I'll tell you what I did. So this was just his CT during dislodgement. You can see the Percoli tubes kind of out of the gallbladder there, not much inflammation. They did a Percoli cholangiogram. It wasn't in, they took the tube out. Next slide. So this was his CT just prior to surgery. On the left side, this was the interval scan that I did. The one on the left side. Yep, other one. So this was the initial CT scan. So his Percoli tube is out now. You can see a little bit more kind of inflammation there. So I put him on some antibiotics just to, I had him scheduled for surgery in 2 weeks. And I scanned him before. So here's his one after 2 weeks of antibiotics. You can play that one. So really the antibiotics didn't change much. There's no air in the gallbladder. It doesn't suggest a fistula to the colon or anything like that. But I took him to the OR. I prepped his colon before the case, so he did do a bowel prep because I was a little worried about the colon. So in the operating room, I did a right subcostal incision. He was like 300 pounds or so. His gallbladder was fistulized to the hepatic flexure. I ended up doing a right colectomy along with the gallbladder, and I did a hand-sewn enticide ileocolic anastomosis. And then we could go to the next slide. I did get a cholangiogram. This is the intraoperative cholangiogram. You can see the CBD is small, and then you can see filling of the duodenum as well. You can go to the next slide. So I think just for the takeaways for this case, or performing an interval CT prior to surgery in patients with Percoli tubes, that's what I do for all of these patients, and it can help determine the inflammation and the timing of surgery. It would be nice to have a drain cholangiogram preoperatively as well to define the anatomy. That was my plan for this patient as well, but his Percoli tube fell out. And then in most of these patients, the colon is pretty close by on the scan, so prep the colon if it looks involved at all. And that's it.
Okay, interesting. a radiologist is asking you, other than the biliary anatomy and common duct stones, what information would be helpful to an HPB surgeon prior to cholecystectomy on a biliary MR? Is the insertion of the cystic duct important to you? The length?
You're muted, Rob.
Sorry, I was unmuted. I like the the cholangiogram through the percoli tube because it can show me how long the cystic duct is as well. So that's what I like. And
any
then
other
the
things on MRI that would help you? I think he's
I typically
inquiring
don't
because
need
what does he want them to be looking for?
What would you like to see on an MRI report before surgery?
Yeah, I think all the points that Dr. Shaw mentions, particularly the length of the duct, I think that gives us, if you have a good long cystic duct, we feel much more comfortable. Whereas if you have a little nubbin, you know that you're going to be right on the common duct. And certainly for the cholecystectomy, when you have a very long cystic duct, those spiral valves, can give us some trouble to try and to get your cholecystoscope down, and dissecting lower down towards the common duct can be helpful. So I think all of those are good points.
Yeah, I guess my only point would be to the surgeons that are on is start looking at your own MRs and not just relying on a report. You can get pretty good to go over them with the radiologist so that you can anticipate what you're going to run into. I find it much more helpful if I look at it myself than just reading the report.
And Frank, and do it for every single case, because I think in many ways there's far too many, as much as I'm pushing cross-sectional imaging, we do too much of it. But you should never go back after a difficult case and say, "Well, I wished I looked at it." That information is always there. So if the map is there, look at it before you go driving.
We really want to thank you for participating. I hope it was valuable. Really good questions in the chat. I loved it. And next is going to be updates on prevention and screening for GI cancer. So that'll be great. And that's going to be next month. So we'll see you all again. If you have topics you want covered from a general surgery standpoint, please give it in your assessment of this webinar. See you next time.